Our group researched the West Nile virus. This video will present information about the biology of the virus, the pathology, the illness.
The West Nile virus, according to the ICTV classification, is part of the Flaviviridae family. The virus itself is an enveloped, non-segmented, positive-sense, single-stranded RNA virus. It has an isohedral-shaped capsid, and it has a single open reading frame with a 5' and a 3' end. Both of these ends are non-coding regions of the genome, and they form structures that make replication, transcription, translation, and packaging of the genes very easy. When talking about the structures of the West Nile virus, they are grouped into primary or structural proteins or secondary/non-structural proteins. The structural proteins are capsid, an envelope, and a pre-membrane. The purpose of all three of these is to aid in viral entry, viral fusion, encapsulation of viral genome during replication. The non-structural proteins include NS1, NS2A, NS2B, NS3, NS4A, NS4B, and NS5. The purpose of NS1 is it's highly immunogenic, and there is a reason to believe that it plays a role in replication. NS3 is the viral protease responsible for cleaving other non-structural proteins from the viral polyprotein. NS5 serves as the viral polymerase and is necessary for viral replication. All of the others inhibit one or more components of the innate immune response against viral infection.
The West Nile virus is spread through mosquitoes, and once injected into the body, it replicates at the site of inoculation, which is the location of the mosquito bite. After replicating, it travels to the lymph nodes in the bloodstream where it can spread throughout the whole body. The virus enters the central nervous system through two mechanisms, toll-like receptors and tumor necrosis factor alpha. Toll-like receptors are primarily found on macrophages and dendritic cells and help initiate the immune response. Tumor necrosis factor alpha increases the permeability of the blood-brain barrier, and once the virus enters the brain, it directly affects neurons, especially deep nuclei and gray matter of the brain, brainstem, and spinal cord. Immune-mediated damage such as inflammation causes most of the pathologic symptoms, and this virus can either cause mild febrile symptoms or serious illness. Symptoms of febrile illness include headaches, body aches, joint pain, vomiting, diarrhea, rash, and can include fatigue and weakness lasting for weeks to months. Symptoms of serious illness include high fever, headache, stiff neck, stupor, disorientation, coma, tremors, convulsions, muscle weakness, vision loss, numbness, or paralysis. %80 of humans that are infected with the West Nile virus display no symptoms. Most of those who do exhibit symptoms experience symptoms similar to febrile illness as mentioned on the previous slide. Less than 1% of those infected with West Nile virus develop neuroinvasive disease. This can be manifested by meningitis, encephalitis, or paralysis. In 13% of these patients, the virus infects the anterior horn cells of spinal motor neurons and causes acute asymmetric flaccid paralysis. This condition is typically seen in poliomyelitis. This paralysis can cause paralysis of the diaphragmatic and intercostal muscles, leading to respiratory failure and death. The risk for encephalitis associated with West Nile virus increases with age and a decreased immune system.
The West Nile virus was first discovered in 1937 in the West Nile district of Uganda. The virus that is now found across the continental United States, Canada, Central America, and the Caribbean islands is an Israeli strand introduced to New York City in 1999. It was likely carried by an infected stowaway mosquito that arrived from plane or cargo ship. The West Nile virus is an arthropod-borne virus, which means that insects carry the virus and can transmit it to other insects, animals, or even humans. The most common vector for the West Nile virus is the mosquito. Other ways the virus can be transmitted include blood transfusions, organ transplants, breastfeeding, lab exposure to the virus, or even poor infrastructure. The graph and chart displays the average annual incidence of the West Nile virus reported to the CDC by age group, and it spans from 1999 to 2017. As we can see, the older you get, the more likely you are to have the virus. Starting with under the age of 10, we have 0.04. From 10 to 19, we have 0.09. 20 to 29, 0.15. 30 to 39, 0.27. 40 to 49, 0.45. 50 to 59, 0.55. 60 to 69, 0.67. And over the age of 70 is 1.15.
The West Nile virus has had a big social impact since it was first discovered in the year 1999. There have been about 37,000 cases reported to the CDC since the year 1999. The largest outbreak of West Nile virus was in 2012 in Dallas, Texas, where 1,590 cases of West Nile virus were confirmed by the CDC. Of these cases, sadly, 889 of them developed a neuroinvasive disease, which is the most severe form of infection that one can get in relation to this disease. Economically, this disease has taken a toll on our nation as well. One research team found that in the 12 years since the virus was first discovered, hospitalized cases of West Nile virus have cost a total of $778 million in healthcare expenses. The good news is that West Nile virus cannot be spread through casual contact. This fact makes the social impact of the virus slightly less damaging because it cannot be passed from person to person when in the social setting. Research is still being conducted in regards to the impact this virus has had on the nation as a whole.
No vaccine or specific antiviral treatments for West Nile virus are available. In mild cases, most people recover without treatment. Over-the-counter pain medications can be used to reduce fever and relieve some symptoms. In severe cases, patients often need to be hospitalized to receive treatment such as intravenous fluids, pain medication, and nursing care. Research is currently being done on interferon therapy for West Nile virus. Interferon therapy is aimed by using substances produced by your immune system to treat encephalitis in people that are affected by West Nile virus. Other potential treatments being researched for West Nile-related encephalitis include polyclonal immunoglobulin intravenous, West Nile recombinant humanized monoclonal antibody, and corticosteroids.